Hello, PsychU community, and welcome to today's webinar, a recovery-oriented perspective and approach to behavioral healthcare, a discussion among a peer and a clinical provider. This webinar is the second part of the initial webinar on the power and impact of a recovery-oriented approach in behavioral healthcare delivery. I highly encourage the audience to watch part one webinar to have a more in-depth understanding of the impact of recovery-oriented approach in behavioral healthcare delivery. My name is Becky Wong, and I am from the Otsuka Field Medical Affairs team, and I will serve as the moderator for our exciting discussion today. Thank you to our participant and audience for joining us. Today's recording is sponsored by Otsuka Pharmaceutical Development and Commercialization INC and Lumbeck LLC, committed supporters of the mental health treatment community.
Recovery has normally been reserved for the substance use field. And in that field, people believed that people could recover from substance use issues. And it was never applied in mental health. And really in the last 20, 30 years, that movement, starting with patients, as they were called, as we don't call them anymore, but who started saying, no, we also can recover from mental health issues. Recovery, the definition has to be defined by the individual. It's not for the provider, the parent, for someone working with the person to define what their recovery will look like, because it's different for each person. So what I might have in my mind as recovery for a person I'm working with might look very different from what they would see as what the recovery would look like. We do believe that recovery can happen for anyone. We feel that recovery should be the expectation for everyone that we work with. We don't want recovery to be confused with cured. There are people who have been diagnosed with mental health conditions who do consider themselves cured, who don't have symptoms anymore, who go on through life and don't take medications and don't seek treatment and are doing much better. There are many people who do not have that fortunate end result. But nevertheless, recovery can still happen. Recovery is about recovering valued life roles, about doing things that are important to you, having a family, going to school, getting married, living independently, getting a job. And those are things that were never afforded or even dreamt of for people who had mental health conditions, serious mental health conditions. I would sit with clinicians and doctors many times and with families and have the families be told that their child, their loved one, was never going to live independently, would never get a job, would spend the rest of their life in institutions, day treatment programs, maybe the hospital. And this was the accepted way. We're happy to know that that is not true and should not be being told to families and to individuals that people can recover. So the other thing we often hear is, well, people have to have insight, they have to have acceptance of their diagnosis. Well, insight is helpful for anything in life. It isn't necessarily something that has to be there for someone to move forward with their recovery. I've had many individuals I've worked with who don't agree with the diagnosis given to them and maybe are in a place where they're not on the same page as the professionals or whomever, and yet they can still get a job, move forward, achieve things that maybe we didn't think possible. So I think we credit Bill Anthony at Boston University with really starting to instill this idea that, oh my gosh, people with mental health conditions can and do recover and do deserve the same dreams and goals and aspirations as anyone else would have.
It had to be around 10, maybe 15 years ago. I was on my way to do a presentation at a hospital in Brooklyn, and I went out of the subway and I was going into a little bodega, but there was a rather tall, imposing individual standing in the doorway, speaking very loudly to himself. I mean, he was obviously agitated, and I had to figure out how am I going to negotiate around this person. Is he someone who maybe is experiencing a crisis right now? Should I call 911? Should I intervene, etc.? And then he turned his head to the side, and I saw his Bluetooth. He was having a conversation with somebody, but automatically I was pathologizing his behavior. And I learned from that. So it goes both ways. You know, you have to be very mindful that not every behavior is a crisis.
Most of us were trained to start with, this is a 32-year-old single white male diagnosed with schizophrenia and the symptoms, and it's all the negative stuff. And it's not that we're not saying that that isn't necessarily important to know as part of the intake, but again, why are we starting there? Because that person is in front of me because of strengths. And I don't want to push them aside and again, label them and further that. So we've always trained our staff, we want to start with, what are the strengths? What's going on? Tell me about what brought you here. And then one of the other things that we really try to do is to ask the person, what are your dreams? So again, I don't use the word goals because that stymies people, I don't know, and they want to give me what they think I want to hear. What are your dreams? And if they can't answer, what were your dreams before, as Dwayne was just saying, before this diagnosis? And I did that once. I was actually training a staff person how to do this, and it was so perfect. This was an individual, a male, young male, who was forced into treatment to us, had this history when he was psychotic of being aggressive and kind of scary was how he was painted to me. And this is not kind of given for the intake, but so be it. And when I asked him, can I ask you what your dreams are? He looked at me and he started to cry. And he said, can I give you a hug? And I said, well, tell me why, what this means to me. He said, because no one in my entire history of receiving mental health treatment has ever asked me what my dreams were. And for that reason, I said, I think it's appropriate to give me a hug. It was a very appropriate hug. Again, that goes back to very different training from when I was trained. And then he opened up and he talked, and he had some pretty bizarre dreams, which maybe weren't necessarily things that we were going to follow up on at that moment. But he trusted me and he engaged in treatment and remained engaged. He did very well. And I think it's because we set the stage differently. You know, when I was a care manager for many years in the field, as a social worker, I was in care management, and I loved it because I got to do all those pieces that were not being addressed in the treatment session. But I spent so much time and going home at night with such nerves because I could not get the individuals I worked with into the programs that they wanted and needed. They were being weeded out. They were too difficult. They've been through before, blah, 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 blah. And it was so pitiful because that's not how an intake should be. There's certain eligibility criteria that you may have for a program. And if that's met, the intake should be, which I start with, is this isn't about whether we want you. This is about whether you want us. They should be interviewing the program to find out, is this the right program for me? Because they're paying for that, whether it's through Medicaid or personal insurance or private pay. So all of those things, you know, and again, yes, you're still going to look at the symptoms and the barriers to what help with getting this person to where they want to be. That's not that we're pretending it's not important. What medications have they been on? What is the history? All of that comes into play, but it's a very different feeling when you're starting from that strength-based perspective, when I'm wanting to know what their dreams are, when I'm giving them the opportunity to ask me the questions. And, you know, just when I say, if you want to be here, you can hear these people, this get so relaxed, because I used to help my clients know what to say in an intake so they weren't weeded out. And our clients, the individuals you work with, are very good at knowing what to say based on what they think we want to hear. It's not what we want to hear. We want to hear what they really have to say.
You know, like I mentioned before, many times the language that we use helps purvey a certain sense of identity. When I used to work with programs who wanted to integrate peers into their services, I would do a visit and I would always notice that there would be client bathrooms and staff bathrooms. And I would challenge the agency to tell me what were the staff doing in their facilities that the clients were doing, which was different. Because that highlights the power differential right there. Mm-hmm. You know, it's very basic, it's very obvious, but it can be so insidious that you forget the impact that that has on how a person identifies their role in their own recovery process.